Welcome to Osteobites, everybody. My name is Anne Graham. I'm an osteosarcoma survivor and executive director of MIB Agents. Today, we get to talk with MIB Agents 2020 Outsmarting Osteosarcoma Research Award recipient, Dr. Andy Livingston. He is joined by Dr. Nancy Gordon, who is with us as well. And we're going to talk about, can osteosarcoma eat itself? I'm really looking forward to this topic. I'd like to tell osteosarcoma lots of things. Eat yourself, just keep it PG. Dr. Andy Livingston is a clinician and researcher at sarcoma medical oncology and holds a joint appointment in pediatric oncology. Dr. Livingston has a particular interest in caring for teens and young adults with cancer. Thank you very much. And is co-director of the MD Anderson Adolescent and Young Adult Oncology Program. His clinical and translational research focuses on developing new treatment strategies for osteosarcoma and other bone sarcomas. Thank you for that too. Dr. Nancy Gordon is assistant professor, Department of Pediatrics at the University of Texas, MD Anderson Cancer Center. Her laboratory work focuses on understanding the biology of the most common bone sarcomas, Ewing's, and osteo, affecting AYAs. Dr. Gordon's major emphasis has been in understanding the biologic properties of the tumor microenvironment that support and contribute to osteosarcoma cell growth in the lung and identify less toxic targeted therapies that can be incorporated into the frontline armamentarium in lieu of cytotoxic chemotherapy. Yes, please. We don't want to keep you, Dr. Gordon. We got to get you back in the lab. Before we out-eat osteosarcoma today, allow me to share what this audience already knows, and that is that it is September, which is Childhood Cancer Awareness Month. Every month at MIB, but especially this month, we at MIB honor, remember, and celebrate the kids who have suffered greatly with cancer. A visible sign across the country at the moment are MIB bows. They're really sparkly, and they're made by families who have been affected by osteosarcoma. If you go to our website, you can get bows and spread awareness and sparkles like me. They're covering everything right now. By putting a bow on your mailbox or adorn your clinic floor or research lab. Clinic packs are available. Just go to mibagents.org/bows. You can pick your region of the country, and there will be an Osteo Warrior family or Osteo Angel family that has bows for you. Okay, so bows, remember that. And in the meantime, Dr. Gordon, would you start the introductions, please?
Well, hello, everyone. Thank you so much for the invitation and the opportunity to actually present our work. I'm very excited to present. I'm actually an associate professor in the Department of Pediatrics Research, and I really I cover all the areas that Anne nicely presented. So yeah, I'm very happy to join and to talk about what actually led to the study that Dr. Livingston and I are running at this point. Thank you.
Welcome, everybody. Great to be here and to join you again. It's always fun to be part of this group and to share with you some of the research we're doing. So my name's Andy Livingston. I'm a medical oncologist. I specialize in treating patients with sarcomas, of course, and have a really big interest, focus, and passion for coming up with new clinical trials and new treatments for patients with osteosarcoma. So I've gotten to speak here in this forum about some of our other work, and I'm excited to share with you about how are we really moving some of the work we're doing in the lab and Dr. Gordon's lab. How is that really coming into the clinic for patients with osteosarcoma? So thanks for having me.
Hi, everybody. I'm Amy Woodchuck, a physician assistant in pediatrics and history in oncology, and overall hopeful for outsmarting, outrunning, outdoing osteosarcoma.
Okay, well, with that, I think let's dive right in. We have a lot we want to talk about and share with you today, and hopefully the talk title was intriguing enough to get you here to hear a little bit about what we want to share, what's called self-eating or autophagy in osteosarcoma. So as you heard, Dr. Gordon and I work closely together in terms of bringing the lab to the clinic. So we wanted to do this talk really in two parts, talking about, what did we learn from the lab when studying these osteosarcoma cells, osteosarcoma models, osteosarcoma in mice, and how can we bring that to the clinic? So first, I'm going to have Dr. Gordon talk about her research. And then the second part, we'll talk a little bit about how did we bring that to the clinic in terms of a current clinical trial we're doing here at MD Anderson, where we're really trying to shut down this self-eating pathway to try to overcome resistance and improve treatments for patients with osteosarcoma.
Well, thank you, Andy. And thank you, everyone. So I really wanted to start by introducing the topic that really led us to the development of these clinical trial. And so with these, I'd like to start by reminding that, one of the main reasons that we actually worried a lot about osteosarcoma is because of metastasis in the lungs. And our focus has been to try to use therapies that can actually directly target the lung. And so for this purpose, we use aerosolized delivery, not only of chemotherapy, as you can see in this case, we also use this approach to deliver some other things such as cytokines and gene therapy. But for this purpose, we use aerosolized gemcitabine, and we try to target directly the lungs. And we use various osteosarcoma models, not only mice, as you can see there, but we also use a canine model. And we delivered the aerosolized gemcitabine, and we showed in both cases that there was significant therapeutic effect of aerosolized treatment in both, as we saw increase in the survival of mice, and we also saw increase in percent tumor necrosis in the canine model, as well as increase in tunnel expression, which is a surrogate for apoptosis or intrinsic cell death. And so next slide, please. However, we actually looking very close to the lungs of these animals, regardless of the dose of chemotherapy that we use in aerosolized gemcitabine, we still saw that there were very small isolated lung nodules that remained within the lungs, and then at the very end of therapy. So this is actually what led us to study the self-eating or autophagy process. Next slide, please. So what is autophagy? So the term autophagy comes from the Greek words meaning self and eating. It's a survival mechanism during starvation that can actually be triggered under any stressful condition. But what's important to know here is that this process can either lead to survival or death. It is implicated in various physiological functions within the cells, and you can see such as nutrient and energy homeostasis, but also involves removal of damaged or unwanted organelles, as well as aggregate proteins and intracellular pathogens. Next slide, please. And as I said, it can be triggered by many different things. And so you can see here amino acids, low energy in insulin, the high ratio of MAP, ATP, and many others can trigger the process. But also what is important to know is that it's related to many diseases, and one of them being cancer. Next slide. And so what the process really entails, and this is a very simple schema that really explains the process, has many different steps, as you can see: initiation, elongation, completion, maturation, and cargo degradation. What is important to understand is it starts by the formation of this double membrane vesicle that is called initially the phagopore. And it's controlled by a main pathway that involves AKT-mTOR, but also autophagy-related genes, as you can see there, ATGs, are throughout the process, controlling the process. And so this double membrane eventually sequestered a lot of different cargo within that could be, as I said, abnormal proteins, pathogens, everything that is abnormal within the cells get encased within this vesicle that eventually closes and forms what we call the autophagosome. And you can see that there are markers of autophagy that are depicted there, such as LC3, which is light chain 3, that can be lipidated. And then that tells us that the process of autophagy is ongoing. And conversion from 1 to 2 tell us like, well, the autophagosome was formed. But also you can see there P62 that can be also degraded, telling us that the autophagy went through the whole process. So there's autophagic flux. Eventually, this autophagosome finds a lysosome, binds to it, forms what is called the autolysosome, and these lysosomal enzymes just get rid of all these cargo and produce nutrients that are recycled within the cells, and this is what keeps the cell alive in a state of inanimation. Next slide, please. And so what we did first was that we wanted to see whether gemcitabine induces autophagy in osteosarcoma. So we took a couple of different cell lines, and we indeed showed that treating the cells with gemcitabine induces autophagy. And we showed these with many different ways. We showed that there was increase in the conversion of LC31, LC32, a marker of autophagy, increase in BECLIN-1 expression, increase in the formation of acidic vesicular organelles, and also increase in the formation of these autophagic vesicles by transmitted electron microscopy, which is the hallmark for autophagy, and decrease in the degradation of P62. Increase in the degradation, so there was decrease in P62 expression. So all these tell us like indeed autophagy was induced by gemcitabine. But what does this mean? Next slide, please. So what we did was we wanted to understand what the effect of autophagy was in these cells and whether when we treated them with a chemotherapeutic agent. And for this purpose, we inhibited the process using both. We knocked down a gene that is implicated in the autophagy process. In this case, we knocked down BECLIN, or we treated the cells pharmacologically using hydroxychloroquine that we know is a pharmacological inhibitor of autophagy. And so in both cases, we showed that inhibition of autophagy, either by knocking down the gene or using a pharmacological agent, decrease the viability of these cells, meaning that make them more susceptible to death and more susceptible to gemcitabine. And this will tell us that autophagy in this case was acting as a resistant or survivor mechanism in this particular cell line. So we wanted to see what happens with the other cell line. Next slide, please. And so when we look at the CCHOSD cells, we did the same thing. We used the pharmacological inhibitor hydroxychloroquine. We knocked out the gene. We saw the complete opposite effect. So we saw that in this case, when we inhibit autophagy, we increase cell viability. So we make the cells resistant to chemotherapy. And in this case, then we conclude that autophagy was actually acting as a cell death mechanism. So there was no need to inhibit the process in these cells because in this case, autophagy was helping the cells to die. Next slide, please. And so in summary, up to this point, I have shown you that gemcitabine induces autophagy. And in many different cell lines. We not only showed in the CCHOSD, we showed in the LM7, we also looked into another murine osteosarcoma cell line, K7 and 3, and the reason for it was because we wanted to know whether this was species specific, and it wasn't. It was also induced. And also we wanted to know whether it was chemotherapy specific. We showed that using a different chemotherapeutic agent, we saw the same duality. And we showed induction of autophagy by different ways, as you're seeing there, electron microscopy, conversion of LC31 to LC32, degradation of P62, and also formation of acidic vesicular organelle. And then, however, when we inhibited autophagy, in the case of LM7, we induced cell death. But in the case of K7 and 3 and CCHOSD, we enhanced cell survival. So then the question was, so what determines whether induction of autophagy will lead to survival or death? And this is the question that we're trying to answer at this point. So one of our graduate students in our lab, what she did was that first of all, she used this phosphokinase array because she wanted to know whether, what was the mechanism that was involved in gemcitabine-induced autophagy. We know overall that the standard mechanism that has been described is it's through the AKT-mTOR signaling pathway. So she indeed showed, as you can see there in green, that the AKT and mTOR signaling was decreased, which is what you want to see. And so the mechanism was clear. So there wasn't anything different from that in the mechanism. But what we saw in this array was that this heat shock protein 27 was increased. And that kind of caught our attention. And so keep in mind, HSP27 was induced in LM7 cells when they were treated with gemcitabine. And remember, in these cells, gemcitabine, when we treated the cells with gemcitabine, induction of autophagy will lead to survival. And this is in these particular cells. And so then we went ahead and looked into these using the CCH-OSD cells. Next slide, please. So, and we actually showed that indeed the mechanism was the same, where there was decrease in mTOR signaling and AKT. However, when we look at phospho-HSP27, here we saw that there was a decrease or downregulate. There was really no expression of HSP27 when these cells were treated with gemcitabine. And remember, in these CCH-OSD cells, we saw that gemcitabine, induction of autophagy by gemcitabine will lead to cell death. So, you know, telling us that perhaps HSP27 might act as a biomarker to define what would be the outcome of chemotherapy-induced autophagy in osteosarcoma. Next slide, please. So what are HSP? Very shortly and simply are a class of functionally related proteins whose expression is increased when cells are exposed to elevated temperatures and other types of stress. But what is important to know is that phospho-HSP has been described in some diseases, including cancer, and also has been correlated with resistance to chemotherapy. Next slide, please. So the next thing that we did was just like we got rid of HSP27. So what we wanted to know whether it's what happens when we get rid of HSP27 in the cells. I mean, do we revert the process? And this is indeed what we saw. In the absence of HSP27, inhibition of autophagy decreased LM7 cell sensitivity to gemcitabine. So these, in general, was telling us there was a link perhaps between HSP27 and whether induction of autophagy will lead to survival or death. And this is very preliminary. Next slide, please. Andy went ahead and looked into HSP27 expression in primary bone tumors from patients as well as pulmonary metastases, and he saw that there was variability in the expression of HSP27. And then he'll tell you what this means later. And so in general, our working model was, next slide, please, that treatment of osteosarcoma cells with gemcitabine next in the LM7 will lead to increased phospho-HSP27, induction of autophagy, and when we inhibit autophagy in these cells, then we increase cell death. However, treatment of CCH-OSD and K7M3 cells with gemcitabine will lead to decreased phospho-HSP27, will induce autophagy, but inhibition of autophagy will lead to cell survival. So with this, I will end. I'm happy to take any questions now or at the very end of the presentation, and I will let Andy complete our story. Thank you so much.
Awesome. Thank you so much, Nancy. You know, I think it was really fun. And actually, as some of this work was going on, I had the opportunity to work in the lab directly with Dr. Gordon and really think about how does this story go forward in osteosarcoma. And what was kind of cool around the same time as we were making these discoveries, Dr. Santiago O'Farrell from our lab and Dr. Gordon, you know, in the medical literature, actually, there were several papers saying, hey, this autophagy story in osteosarcoma is interesting and relevant, and maybe this is something we could really bring to the clinic to better help patients with osteosarcoma to overcome resistance to chemotherapy. So, one of the first questions I asked was to say, well, how relevant are all these markers that we're finding in the cell lines actually in patients? Not patients treated with gemcitabine actually, but patients who receive standard chemotherapy like MAP chemotherapy, where most patients will receive as the standard in the United States. So what we did was look at a couple hundred samples actually from pre-treated, at diagnosis tumor samples that were taken out from the time of surgery after chemotherapy, and also looking at osteosarcoma lung metastasis once they were removed from many, many patients. We found a lot of interesting things actually, but I'll just highlight two here, which is we looked at this marker called LC3B. That's one of those autophagy markers. And when it's up, it says these cells are engaged in this cell-feeding process. And what we found highlighted in the red box here was that about half of all osteosarcoma patient samples, we actually saw, yes, there is evidence autophagy is going on. And actually that it's much higher after chemotherapy, which is kind of what we would expect, right? Chemotherapy is that stress. We're stressing those cells. They're turning to autophagy to try to maintain their energy. So in about half of the tumors that were removed after chemo, we saw that. But even highest was in the lung metastasis, where about 2/3 of the samples had high levels of these autophagy markers. And then the other question we asked in this study was to say, okay, well, that's very interesting, but how does that correlate with really how patients do over time? As Dr. Gordon was saying, could these be biomarkers to tell us about treatment or tell us about prognosis, tell us about osteosarcomas that may respond better or not respond to our standard treatments? And so over here in B, this is looking at that protein called HSP27, heat shock protein 27. Here is in the patient samples for patients who got chemo, went to surgery, and we looked at the time of surgery after chemotherapy, and we found that patients with very high expression of this HSP27 actually had lower cure rates, that if it was high in the tumor, that was not a good thing, that those patients didn't do as well long-term. So I thought this was really interesting to tell us, there is a story here. HSP and autophagy are seen, HSP27 and autophagy markers are seen in patients with osteosarcoma getting standard treatment. So maybe we should try to tackle this for patients who have metastatic disease. So thinking about how we could bring this to the clinic, I think many people have probably seen this paper that's come out now a few years ago, which was really a summary of clinical trials run by the Children's Oncology Group for patients with metastatic osteosarcoma. And they looked at the data for 7 phase 2 trials and found out that, we've tried a lot of things. Those things haven't worked that well, unfortunately. And by 4 months on these experimental treatments, about 80 to 90% of patients, the tumors are continuing to grow. So we wanted to use that as a comparator and think about, what are some of the standard treatments out there that really ties this story back to the lab, what we were seeing in the mice, even from those aerosolized treatments. And we looked at gemcitabine and docetaxel, 2 chemotherapies that have been around for a long time, but with a little bit of a controverted story in osteosarcoma about are they helpful or not. Most of the studies that had looked at these chemotherapies in osteosarcoma were what we call retrospective, or looking backwards over time, who got patients who got these treatments, and the story is a little bit variable. This is just summarizing those studies. But in the bottom line here, probably the largest series to date came from the Rizzoli Institute, where they looked at 35 patients with osteosarcoma who got this standard chemotherapy. And they saw that at 4 months, almost half of the patients had disease control. So actually, that's pretty good when you compare it to that prior slide I showed you, where only 12% of patients on clinical trials for osteosarcoma are really benefiting at 4 months. These standard chemos seem to have some activity. So really the question we came to was, well, if this chemo works for some patients, 1, can we figure out who it works for? And 2, how can we make it work better? And of course, you kind of know the punchline here, which is autophagy. So, somewhere I lost a slide here. So what we did in this clinical trial is take these standard chemos, gemcitabine and docetaxel, and combine them with this anti-malarial drug called hydroxychloroquine. It's been around for a very long time. It's inexpensive, it's readily available, it has very few side effects, and it's not a chemotherapy. So can we take this inexpensive medication, which has been shown in the lab with Dr. Gordon and others to really shut down this autophagy or self-eating, can we combine that with chemotherapy to make it work better? So that's exactly what we're doing. We have a current clinical trial here for patients with metastatic osteosarcoma where the tumors have returned or spread to the lungs after standard treatment. And we're doing this in two parts, phase 1 and phase 2. In phase 1, we're looking at what's the safe dose of hydroxychloroquine using really standard dose of chemotherapy. And in phase 2, we're enrolling additional patients, treating them with this treatment to really understand how effective is this treatment for patients with osteosarcoma. Of course, we want to learn a lot through the study. So we're also trying to understand what's the response rate or what percentage of patients have shrinkage of their tumors. How safe is this combination? What are the side effects in treating patients with this? And how does this influence things like survival rates? Of course, we want to understand more about, is the drug doing what we want within the osteosarcoma tumors? And so one of the cool things about working at a place like MD Anderson and really engaging in translational research is we could take this story from the lab, bring it to the clinic in this clinical trial. But we want to learn as much as we can from the study to bring that back to the lab to try to make these treatments work even better. And so the way we do that is through exploratory studies, or what are often called correlative studies or translational studies. And so kind of walk through some of the things we're looking at as part of this trial. So one is we're looking at PET scans for patients who get the treatment. Do we see, really the question we're trying to answer there, do we see early signs that we're shutting down the tumor growth and metabolism with the combination? Next is that, patients who've been treated on this study, we're looking at their osteosarcoma tumors prior to treatment, and then also a biopsy after they're treated with the chemotherapy and hydroxychloroquine. And we want to understand, are we shutting down this pathway? Are we blocking autophagy? I mean, that's the idea, that's the hypothesis. How successful are we? We're also really interested in looking at some specific genes or pathways to better understand who are the patients or which tumors are most likely to benefit from this approach. So here's two genes that we're interested in that in other cancers have been shown to potentially predict sensitivity to hydroxychloroquine. So we're looking at these gene levels. And then in the end, what we really want to try to understand better is which patients really did the best with this treatment. And are there markers in the tumor, in the osteosarcoma, that can tell us this is a person who's most likely to benefit, most likely to respond from this treatment? And if so, can we use those markers, usually genes or protein markers, to really create the next study where we say, this treatment's going to be best for this set of patients with osteosarcoma? And then lastly, we're doing some more broad-based testing using something called functional proteomic profiling, or RPPA analysis. And really what this does is looks at all different proteins and changes in proteins and various pathways within the cell to really understand what are all the ways we're changing what's going on in those tumor cells. Really to try to understand even better how does this autophagy process link to, to the tumor cell and cell death. Okay, so here's the overview, or here's what the study looks like. Basically, as I told you, it's a phase 1-2 trial. We're combining gemcitabine docetaxel, the standard chemotherapies, with hydroxychloroquine, which is a pill, and specifically for patients with osteosarcoma. So when patients are put on, enroll onto the study, they have either, we either get a piece of their osteosarcoma from their prior surgery, or we do a biopsy prior to starting the treatment. Patients take the hydroxychloroquine pills every day, and then actually twice a day, and then get gemcitabine and docetaxel IV chemotherapies on what is a pretty standard schedule. Each cycle is 3 weeks, and so after 2 cycles or 6 weeks, we do another biopsy of the tumor to understand how is the treatment affecting the tumor, and then we get scans to see how well is the treatment working. When the treatment's working well and patients are having few side effects, they stay on this treatment. And we typically get new scans about every 2 cycles or every 6 weeks. And patients can stay on the treatment basically for as long as it's helping them. So it's a great time, a perfect time to get to share this with you, because now we've actually had the study open here for probably more than a year. And we've completed the first part of the study, the safety part of the study, the dose part of the study, dose finding part of the study, and we're actually in phase 2. So it means we know or think we know what's the right dose of hydroxychloroquine, and we're enrolling more patients now to really understand how effective is this treatment. And we've actually treated more than 15 patients with osteosarcoma on the clinical trial. It's a little too soon to share with you about the patient outcomes. I'll look forward to updating you in this forum and at some upcoming scientific meetings where we can share our results about patients. But it's really cool study that we have, and we have been successful at collecting these tissue samples, these tumor samples. Dr. Gordon is taking those back to the lab to look at things like autophagy and this marker HSP27 to really understand, again, who are the patients who are most likely to benefit from this treatment. Just briefly, here's a very brief version of some of the eligibility criteria. Who would be potentially eligible to be treated as part of this study. We're looking at teens and adults, so over the age of 12. Of course, patients specifically with osteosarcoma, and patients must have received previous treatment with what would be a standard regimen like MAP chemotherapy. We really don't think, although this is exciting, we don't think this would replace the standard treatments with drugs like doxorubicin, cisplatin, and methotrexate. Because we need a way to kind of measure or see how well the treatment's working, patients have to have what's called measurable disease, or a tumor that could be measured, like on a CT scan or MRI. And in general, we want to make sure that patients are healthy enough to do the treatment safely in terms of their blood counts, their kidneys, and their liver function. And lastly, because we are doing biopsies as part of the study, patients who are on our study, who choose to enroll on the trial, are asked to have a research biopsy so we can really understand what's going on. We want to include as many patients where we think they could be helped, but there are a few exclusions, or patients who wouldn't be eligible for the study, mainly patients who've already received this type of chemotherapy, or if for some reason they're not able to swallow the hydroxychloroquine pills. So I will wrap up there. And I want to encourage you, of course, to reach out to Dr. Gordon and I. I'm happy to take your questions now. If you're interested in the science, if you're interested in the clinical trial, please don't hesitate to reach out to us. Actually, this clinical trial is listed on clinicaltrials.gov. Here's the number, which, sometimes it's hard to look it up by the number, but if you put in osteosarcoma and autophagy, or osteosarcoma and hydroxychloroquine, you'll find information about our study. And please reach out to me by email, or you can follow me on Twitter as well.
Great. Okay. Really exciting. Really exciting. I'm so excited. This is in phase 2, and it's for kids who have failed treatment and have measurable metastases. Yeah. So if their liver is in good shape or reasonable shape, and they've come through their first line chemotherapy, it's okay to have distant mets.
That's right. So, there's all different trials going on here and nationally for patients with osteosarcoma, and they all have a little bit different rules or criteria about who could be or should be treated on that study. For this trial, you're exactly right. It's patients who've had standard treatment, and the osteosarcoma either didn't respond, had grown on the standard treatment, or they were done with treatment and then something new comes up, like most often would be a metastasis in the lung. And for our study, and this is kind of one of the things that differentiates some clinical trials, is that patients have to have a tumor in place that could be measured. So for a patient who has a lung nodule or a lung metastasis and has that removed by surgery, this wouldn't be a study for that patient. There are other studies for that patient, so that's good. And if you're interested, let me know. We can try to connect you to some of those studies. But yes, in this study, it would be patients that have tumor that we can see or measure on a CAT scan, who've had some of the standard treatments. And you're right, we do look at things like the kidneys, liver, and blood counts. But really the rules around that are the same ones that, your doctor or your oncologist would already be using to see, are you safe to receive the chemotherapy? So it's not meant to be restrictive. Really, it's just about, can we do this safely?
So follow-up question on that. You're measuring at the outset when you have the patient in front of you, you measure their or you how do you do that? How do you do the DNA test to see if they have these markers, or how do you test to know if somebody has this protein? Is that just a blood test?
Yeah, so it's a great question. That's part of what we're trying to learn on the study. What we're doing is we think that the markers in the tumor are the most important. So sometimes we use blood-based markers, but for this autophagy and HSP27, we think that what's it doing in the tumor is the best predictor. So for this study, we're asking patients that they would either have a biopsy prior to starting the treatment or give us access to some of their tumor specimens. So many patients with osteosarcoma, of course, have had surgery, have had prior biopsies. Those are usually saved in what are called tissue blocks, wherever the surgery was done. And so we ask that they'll send us some of that tissue, some of those slides, so that Dr. Gordon can take it to the lab and look for those markers. But actually, for this study, we're not, whether or not you have the markers doesn't say whether or not you can go on the trial. That's what's called a selection biomarker. Our theory, our hypothesis is that if you have these markers, this treatment will work even better. But we don't know. And actually, that's part of the scientific question we're asking. So we're collecting those tissues, those tumor tissue samples, to really ask that question. And we hope that once we finish the study, we really hope to better answer that question and understanding, who are the patients who really did well with this treatment.
There's some questions on the board here about considering maintenance therapies. So is there any thought or clinical evidence to support use of the hydroxychloroquine as maybe a maintenance or preventative medication? And then is there any thoughts, or do you have any thoughts, either of you, about repurposed drugs or supplements for maintenance therapies?
So, I think these are two really great and related questions. So I'll go first, and then I'll let Dr. Gordon talk a little bit about, repurposing drugs as well. I think one of the advantages of a medicine like hydroxychloroquine is that, it's inexpensive, it's readily available. We know it's a safe medication for other uses. It's been around a long time, and it tends to have very few side effects. So those are the kind of things that sound appealing in terms of thinking about a maintenance type medicine. But with that said, we don't really know, we don't really know the answer to that question. Could taking a medicine like hydroxychloroquine after you're done with your treatment be used as a maintenance strategy to try to prevent osteosarcoma from coming back? I think it's a really good question. I mean, I think that's an area of really unmet need. Patients who have a high risk that the osteosarcoma is going to come back, and often feeling like, well, what do we do now? What else can we do? Is there something that we can do safely that kind of meets those other criteria I was mentioning? Something that's safe, something that would have few side effects that we think would be helpful. But I think for hydroxychloroquine, it's a little bit too soon to know, does it fit in that role?
So I'll add here that when we talk to repurposing, drugs, it's like one of the things that that's why we took like the aerosolized approach. And one of the reasons is because we know that using gemcitabine, delivered systemically by IV, first of all, we have to use a much higher dose. And then you have certain things that are, impact your bone marrow. So, the patient is already receiving chemotherapy, so it's getting very immunocompromised. So then how can we actually do something, since our main target at this point will be the pulmonary metastasis? How can we use this drug that we know that might have some activity, but use a different approach where we can decrease the dose, target directly the lungs? And so that's what we actually use the same drug, but we are delivering by aerosolized. And the other thing is, like, another thought was like, we all know that there is a gap between, when the patients go to surgery and get their primary tumor removed, but the time the chemotherapy is restarted again. So during that gap, nobody really knows that, you still have cancer cells probably within your system. And that's where we kind of like do consolidation therapy. And at this point during that gap period, we also showed that, that you can possibly deliver these aerosolized gemcitabine. And in that way, you cover that window with some chemotherapy that is effective again was your more threatening thing, which is like lung metastases. And then yes, and we don't know if we actually can give these as a maintenance chemotherapy yet. We have another study where we're testing safety of this approach, delivering aerosolized gemcitabine. We don't think aerosolized gemcitabine by itself will do the trick completely, but it's during this window period is a safe way to deliver chemotherapy to try to kind of like keep the tumor under control.
The aerosolized version of gemcitabine, I think that's absolutely fascinating because, as you point out, it's going straight to your lungs if it's aerosolized. Like that, what a good idea.
Yes.
That seems like a really fantastic thing. And I wanted to say, having been an osteosarcoma patient, I remember like it was a day on the calendar, like, and we counted down the whole time to get to that end date when you're done with chemotherapy. And then when you get to that date, you're like, oh my gosh, now what? Like, it feels like you're being set off into the wild and you're like, what do I do now? And like, when do I get to come back? Because it's kind of like having a baby where you like leave the hospital with the baby and you're like, what do I do now? Wait, you're the baby to be responsible for this thing? Like, but in a much more treacherous way. When you leave the hospital, you're like, and I can't imagine, but I can imagine how hard it must be as a parent to have your child leave the hospital for the last time having the standard of care chemotherapy and just hoping that it sticks. So there is that thing where you can't wait to be done with it. And then you're like, oh my gosh, I'm done with it. Like, am I going to be okay now? Like, I feel like I need to do something else, which is why mifemertide is is something that we're all keen to have be standard of care post standard of care, that we can stay on something like that to hopefully try and maintain NED. So yeah, it's a funny thing. So along those lines, that Rizzoli Institute study is kind of an interesting one, right? With people not relapsing as much if they've gone on that gemcitabine and docetaxel, right? Post.
Correct.
So, I mean, the numbers were fairly significant there. Any chance that becomes something that we get to do here?
Well, so
study, I'm sure, but
yeah. So actually, in that study, what they looked at was mainly patients who had already had a recurrence, where they had come back, the tumor had come back or spread or was resistant to the original treatment. But I do think, I agree with you, it's pretty compelling that the chemotherapy works. I showed that table to say that there have actually been a lot of different studies looking at gemcitabine alone or in combination with docetaxel and osteosarcoma. And there's kind of been a debate. I mean, are these drugs really that effective? But I think the Rizzoli study shows us that they are effective, and actually probably more effective than some of the things we've recently studied in clinical trials. And even medications that now are becoming used more often in the clinic more and more based on recent studies would be drugs like regorafenib or cabozantinib. And those studies similarly looked at how much can we prevent the tumors from growing or spreading. So, to me, I think the Rizzoli data tells us, gemcitabine docetaxel should certainly be part of the toolbox somewhere in the armamentarium, that we shouldn't write it off. And maybe this is a way to make it better. And I think part of what you're asking and thinking about is, again, could we add that in addition to what we're doing? Could we use that as another way just to reduce the chance of it coming back? But really, I think the challenge is, although these treatments are pretty effective, that like almost all the treatments we have, they have a lot of side effects. And so I think before we really embark on that with these chemos or other agents, we have to better understand who are the patients who are at the highest risk, ones where, we'd be willing to take on those side effects if we really thought that was going to have an impact. Because we also need to remember fortunately, there's many, many kids, young adults and older adults who are cured of their osteosarcoma with our standard treatments. And so I think that's really the balance. How can we position all of these different treatments to really figure out who's the most likely to get the most benefit?
Isn't genetic testing an important piece of that, deciding who's likely to relapse?
Yes, sort of, I think is the answer. It's also an evolving piece. And I'm sure some of the speakers in this forum have spoken to that. We're really trying to understand from a genetic basis, looking at the tumor genetics, which are the most aggressive osteosarcomas and which are the better behaved. And in some ways, it's the next evolution of things like looking at tumor necrosis. For so long, we've held on to how much a tumor is dead from MAP chemotherapy. And that's still hugely important, probably the most informative piece. But really, the tumor genetics or DNA testing can allow us to take a deeper dive into understanding what are these different subgroups. This is a favorite topic amongst osteosarcoma clinicians and researchers, is how can we really better divide these osteosarcomas, I should really say the tumors and also the patients, to understand who's most likely to be in that long-term survivor category, who's at higher risk for having the tumor come back or the sarcoma come back.
Yeah, popular among patient families as well. Like, who's really at high risk, and there is that space where you leave the hospital and you're done with treatment and you just don't know, and you're every cough, every pain, you go, oh my gosh, do I need to go back? Is it back? Is it back? Is it back? And this cancer, I'm sure a lot of cancer patients and survivors feel like this, but osteosarcoma to me is such a stalker. Like, it just stalks you. And every time you're looking around the corner all the time to see, is that it? What was that? Was that it again? Is it after me again? And anyway, so yes, Amy, any questions from you?
There's a question from the field wondering if you could just go over quickly the side effects that you've seen from the trials with gemcitabine and docetaxel.
What are the side effects with these medications? I'm happy to go over it. In general, the side effects we've seen on the trial are really in line with the side effects of the standard medicine. So, I hope I was clear in explaining that gemcitabine and docetaxel are standard FDA-approved medicines used very often in pediatric oncology, used often by sarcoma doctors for bone and soft tissue tumors. And so we know pretty well what the side effects of those medicines are. And part of what we wanted to do, at least in the phase 1 part of our study, was to try to understand, does adding hydroxychloroquine increase the side effects or change the side effects? So actually, most of what we've seen in terms of side effects, I would say, are expected. Things like fatigue, low blood counts. Patients may need blood transfusions. Sometimes when patients have low immune cells, low neutrophils, they can have fever. Those are actually by far and away the most common side effects. Sometimes the adding the hydroxychloroquine we think can lower the blood counts further or make the blood counts slower to recover. Some of the other side effects that hydroxychloroquine is known to have, particularly when we use it in high doses like on this study, is for some patients it can cause some stomach upset or nausea, and occasionally can cause things like rashes or dry skin. But I would say actually across the patients that have been treated on our study so far, we've really seen that most of the side effects are kind of what we would expect from this chemotherapy.
Okay, just for clarity's sake, we're not in any way suggesting that if somebody could get their hands on hydroxychloroquine, that they should and take it as a preventative, correct?
Yes.
I think that is correct. I know that is correct. You know,
Absolutely
of
correct.
course, people have probably heard or remember hearing a lot about hydroxychloroquine in the last year or last 18 months. There was a bunch of enthusiasm with its relation to COVID-19 and could it be effective there? And interestingly, around that time, we had a little bit of trouble getting supplies for the medicine there was a global shortage because everyone ran out to get it. And I think that's a little bit of a cautionary tale just to say, you know, as much as we're excited about data, we want to do things that are helpful. We should really follow the science. Speaking now about osteosarcoma and hydroxychloroquine, which is that, you know, again, although we think this medicine is safe, you know, it's certainly FDA approved for several different conditions. To me, I don't think we have enough data that I would recommend an osteosarcoma patient just start taking hydroxychloroquine. You know, I hope people are interested. I hope this is a compelling idea, but I would really suggest if it's something you want to pursue that you do that under the guidance of your oncologist or as part of a clinical trial. You know, when people do things outside of that, we don't have a good way of learning, you know, about the side effects, about the safety, or about how helpful it is.
Yes. Thank you. Okay, we are just about out of time. So I want to add that if you're looking for this or another clinical trial, you can find an osteosarcoma specific clinical trial on MIB Agents website. We have a platform where you can put in your quick data like location, what you're looking for, and in under 60 seconds, you can find an osteosarcoma specific clinical trial. This has been such a transformative tool, and it's been a great tool to help recruit for clinical trials because it's so easy to find, and it pulls from clinicaltrials.org. So we're not making it up. It's a real thing. So that's on our website if you're looking for a clinical trial, including this one. This one will pop up for sure. And we're pleased to know that doctors and patient families are using this tool to find the right trial for them. Okay, so it looks like no other questions. So we'll wrap it up by saying thank you to Dr. Gordon and Dr. Livingston. More information on this trial and on all Osteobites can be found on YouTube, on our MIB Agents YouTube channel, on mibagents.org, or anywhere you get your podcast. We now have quite a library of information on all things osteosarcoma, research, innovation, and hope. If you registered for this particular Osteobite session, you'll be emailed all the links that we talked about shortly, along with the link to this video. Next week, we're going to have another excellent Osteobites guest. We'll be having Dr. Abha Gupta on. She is with Hospital for Sick Kids and the Princess Margaret Cancer Center. She'll be talking about fertility preservation in patients with osteosarcoma. So really looking forward to talking through that very important topic. Until then, thanks again to Dr. Gordon and Dr. Andy Livingston. Thank you for using your powers for good. I know you do. I really appreciate that. And thanks to MIB superhero, volunteer, and physician assistant, Amy Woodcheck. We'll see you next week. And don't forget to get your sparkles on. Thanks, everybody.
Thank you.
Like and subscribe.
Like and subscribe.